I think most of you know who I am. I've poked a few holes in most of you, and hopefully helped. This particular lecture is about spinal cord stimulation for pain control. And it's one of my favorite things to do. It's minimally invasive, very safe for the long term. And it seems like every 6 months we have new indications for this technology. This is very unique. This particular company, Nevro, is the newest spinal cord stimulator company, and they have patented technology using high frequency energy that I'll go over with here in this talk. So I see you have company, Sebastian.
Yes, I do.
Good, good. It's always good to have an extra set of ears.
That's right.
So I have the Nevro representative, Elizabeth, with me today, and they make this slide presentation available to me. I've given it about 1 million times, however. And I just wanted to share some information with you about this and about the availability here at Valley Surgery Center. So chronic pain, by definition, based on the textbook you read, is pain that's persisted for 3 to 6 months. And everybody that's listening to the presentation tonight has certainly had their pain for greater than 3 to 6 months. But that defines chronic pain. And it can be injury, it can be infection. There are a lot of things that can cause pain. It often has, unfortunately, a big emotional side to it that results in depression, anger, anxiety. All of you have experienced those things. And when I watch you guys in pain, some of you I help, some I wish I could help more. I experience those things too, because I want the best for all of you. And that's why I'm talking about this tonight. This technology will probably apply to quite a few of you. We kind of pre-screen people to discuss this with. So let's back up one slide. So generally speaking, these are a little bit old on the statistics, but it's from 2006. But in 2006, I mean, come on, 14, 15 years ago, pain cost the United States $600 billion. It's certainly over $1 trillion now in treating pain. 8% of the population suffers from chronic neuropathic pain. That means there are nerve injuries involved. The majority of the pain is chronic low back pain. And certainly, as I started this business with the neurosurgery group in town, I dealt with a tremendous amount of chronic low back pain, both before and after surgery. And many of you have had one or more back surgeries and are a little disappointed in the results. Quite often people feel pretty good for a while, and then some of the pain problems seem to come back, either caused by the original injury or exacerbated by the trauma of surgery. So the basic things that we do for you guys, after you're lucky enough to get an appointment, that's sometimes hard to get, especially now that I'm retired. But fortunately, Dr. Rhodes has taken over a lot of my patients and has a very large practice himself. So he helps me preach the gospel to everybody about some of these advanced technologies. But we always start with pharmacological therapy. As you all probably know by now, the federal government frowns on that now. The attitudes changed and so forth when OxyContin was introduced, which is a pretty gnarly drug. OxyContin, just so you know, contin means continuous when added to a drug's name. And oxy is simply Percodan, Percocet, it's all the same stuff. And the different brand names, they're all owned and manufactured by the same company, but they are all just time release. So contin means continuous. And most of you have been through pharmacological therapy, and I've realized that there are a lot of downsides to that. So I am a board certified anesthesiologist and pain doctor in interventional pain, and my entire goal was to become the lowest narcotic prescribing board certified pain doctor in California, and I met that goal before I retired. In my last 2 years, I didn't write, but about 250 narcotic prescriptions, and I had about 5,000 or 6,000 active patients. So I was able to control their pain to the point where they could get off some of these drugs that unfortunately change your life in a negative way over time. But we try pharmacological therapy. We certainly try lifestyle changes, avoid the things that cause your pain, quit dirt bike riding, quit snowboarding, things like that. And of course, all of you have been through some mode of physical therapy, either self-directed or professionally guided or both. Then when those things kind of fail or don't produce the results, why typically people are sent to me and I do nerve blocks, things like epidurals. When I have said to the public that I'm a pain doctor, they go, "Oh, you do epidurals." And if you were to look at my schedule every Tuesday when I do procedures, and I'll have 25 to 35 patients in a day, an epidural is the least likely thing that I provide. There are many, many injections involved in pain management. Fortunately, I do just about all of them. Then we move to more advanced things like surgery, or in the old days, I used to implant narcotic delivery systems, pain pumps. I reserve spinal cord pain pumps, not for pain, but maybe indirectly for pain control, but for movement disorders like multiple sclerosis and so forth. But I really enjoy spinal cord stimulation as a therapy, especially since I was introduced to the high frequency stimulator that is produced by Nevro. And since I put my first one in, it seems like 8 years ago or so, I haven't used any other brand. I was an educator for a dozen years for Medtronic Corporation, who invented all of this stuff. And this, this therapy by Nevro has pretty much overshadowed all the other low frequency stimulation systems. I'm just changing slides here. There we go. So spinal cord stimulators, it works by delivering small impulses. And in the case of Nevro, they're high frequency impulses. And just remember dog whistles. They're very high frequency. The dogs can hear them. You can't. Well, I'm sure some animals can feel this stimulation. Humans can't feel this when it's active. Unlike the low frequency devices used in the past, and I have a lot of experience with those, you can get shocked, you can move funny, it might buzz you, very much like a TENS unit can get out of control. This therapy was invented in the 70s and got refined. And I think the 4 or 5 companies that are out there did a great job, but this high frequency stimulation is great compared to the other systems. We use it for pain in the back. This is the only stimulator that's approved for what we call axial pain or spine pain, so back pain, neck pain. But generally, we're treating the trunk, the back, the limbs, arms, legs. There are some new indications for diabetic neuropathy, probably in America, the #1 cause of neuropathic pain and the most common cause of peripheral neuropathy. And that's when your feet and hands eventually burn. And we see that in diabetics, a tremendous number of diabetics develop that over time. So how does it work? So I'm going to go through this list with you. This is actually a video, but we're going to show still images so it doesn't go by too quickly. We're just changing some slides here. So the way it works is we place some very small electrodes. Electrodes are little plastic coated wires, so to speak, with little electrodes on the end. We have in our system 8 electrodes on each wire. We put 2 wires in everybody. The way it works is we ultimately put in a small pacemaker device that's programmed to send impulses to these electrodes that are placed in specific places in your spine. The beauty of this system is we don't have to be pinpoint accurate. All the old systems would take a fairly long time to figure out if we had the electrodes very close to the injured nerves. And that doesn't happen in this particular system. This is truly, for instance, in the case of low back pain, the small little electrodes, which are smaller than a pencil lead, are placed in an epidural space, very much like a mom has a baby. We put a needle in, slide in a small catheter. This is simply like that catheter, but it has the little electrodes placed inside. We place them up right about where the bra strap sits on a woman. Hopefully not you guys. And right in that zone is where the back and leg nerves come to the surface of the spinal cord. So we can easily stimulate those systems, those nerves with this system. Again, you don't feel a doggone thing when we turn it on. In the old days, we had to find those nerves and buzz you, sometimes quite uncomfortably, and say, do you feel that in your foot? Do you feel that in your leg? And so forth. In this system, we simply put a couple of electrodes right at about the T9-10 level, which again is right at the lower part of your scapula. And that's the magic spot for back and legs. We rarely, if ever, have to adjust them. We put them in, we sew them in, and connect it to the small little pacemaker, and you're done. Now, prior to that, we do a trial. And the trial is about a 15 or 20-minute procedure where we place the wires through the skin like a mom would have an epidural. We, under X-ray, place the electrodes so they're at that magic sweet spot, and we turn it on. We have securing devices so we can tape it to you. We actually leave it in for 1 week. The entire time, Elizabeth, my representative for this company, is communicating with you on a daily basis. And we make small adjustments in mostly power setting. Some people can handle a lot of energy. Some people need a lot of energy, but we make these changes remotely. And typically, over the next couple of days, people start to notice relief in the areas that we're targeting. The cool part about it is usually the next day, patients say, well, my back, where you put the needles in is kind of sore. Okay, I would expect that. Because you use X-ray and I've done a million of these things, I'm pretty fast at putting them in, so I don't traumatize people too much. Or you wouldn't come back to me. Then the next day, people often say, wow, that was like the best night's sleep I had in a long time. That's a common statement we hear on day 2. Day 3, people laugh because they forgot to take their pain medicine. So in our trials, about 80% of patients achieve greater than 50% relief. And we've measured that a year or more in patients. Now, Nevro has the best measuring system and recording system of any of the devices. We actually know every device that I've put in, and we know how they work, and I've been putting them in for 8 years. I have never had to take a stimulator out because it didn't work for pain. Unlike the old stimulators, after about 4 or 5 years, when we had to change the battery, the patients would often say, I'm just not sure if I want to undergo the expense to change the battery and stuff. It's just really hasn't been working that well the last year. And that's characteristic of a low frequency stimulator. The current battery that we're using, very small, new edition battery, and it's the generator, the battery, the computer, everything inside. It's all signaled remotely. There's no wire connection to our computer system. And we have followed our patients for the entire time that they've had their stimulator in. And when I said 80% get 50% relief, I've never accepted that as a threshold for putting in a permanent stimulator. So if the patients, they got a trial for 7 days, of course, we're all kind of excited when we first have a new therapy, but that's why I've extended my 3-day trial to a 7-day trial. That gives people a really good example of what could I go do when I had this turned on. I tell people if they're working, go to work. There are very few restrictions. You can't swim when you have the external trial working. But other than that, I tell people to go do yard work, go do whatever bothers you and make a real good judgment as to whether this is helping your whatever we're treating, back or leg pain, neck or arm pain, and so forth. But I shoot for more like 90% of my patients get more like 90% relief. Because I realize we're all excited up front. So if I have stricter guidelines for accepting who gets a permanent stim, I'm much happier, and the patient's much happier if they still have, 80% of the time have 50% relief. We have about 95 or greater percent of people that get the trial actually go to the permanent stimulator, which I think is based on the patient selection that Elizabeth and I do. Plus, the people that now send me the patients have been trained to select better patients for this. The one thing you don't want to do is take someone who's been strung out on OxyContin for 10 years and then try to do an advanced technology like this. It's not going to work until their drug intake is reduced dramatically. And that goes for any advanced pain therapy, even surgery. If you take someone who's on high dose narcotics and try to do surgery, they are never going to be happy, and you're not going to be able to get them off those narcotics. So, as I said, I'm the lowest narcotic pain prescriber in California for a board certified pain physician. So it's worked for me for a number of years, helping people get off those narcotics. And, they trust me to stick needles in their spine, their neck, all over their body. So they kind of trust me when I tell them they're going to be okay coming off these narcotics. So this system provides much better relief. It's well documented how much better it is than the low frequency devices. It doesn't matter one of the 4 companies that makes those low frequency devices. It works better than all of them. You don't feel any tingling. You can't shock yourself. This is even FDA approved uniquely to drive a car with the thing turned on full blast. All the other ones say turn it off when you do those kind of movements, because you might get shocked when you're trying to hit the brake pedal. You can sleep with it on. You can drive with it on. You can swim with it on. So it's a really good system. The batteries now last, by the way, 10 years. And a battery change or generator change is truly a 15-minute procedure to change the batteries. The securing system, can the audience see this particular slide?
If you can see it.
Okay, so this slide that's on, that's the actual generator. It's a very small, smaller than the palm of your hand, thin device. It fits just under your skin if you're happy with the trial. And as I said, we're 95 or greater percent of the people like the trial very much. In fact, the hardest thing I do after the trial is to convince them to come back on their scheduled visit to have it taken out. And we leave it out for a few weeks while your skin heals before we do the permanent implant. But this is what the system looks like. Those little electrodes, there are 8 little electrodes on the end of each lead. We have different size leads and so forth for where I'm putting them. But this is the rechargeable implant. You take something very much the size of a computer mouse, and you place it wherever I put the generator, usually at the top of your butt cheek or in the flank, someplace that you're not going to sit on or lay on. And you place the charger over it, and in about a half hour, it'll charge the system up. We have people top it up every day. It's not inconvenient while you're watching the news or something. Well, nobody likes to watch the news. While you're watching Friends, it'll be charged up by the time you finish an episode. And you have access to those systems to recharge it. Very easy, and the burden of recharging is negligible. In other words, we've done statistical analyses on, are people annoyed that they have to charge it? Well, I'm more annoyed at charging my cell phone. So we've done large clinical trials. This has the highest success rate in returning people to their normal activities. If you're, we have a tremendous number of people that have returned to work after years. And all of us are much more productive. And I think a lot of our anger issues and emotional issues, certainly our financial issues that make all those things worse, are improved if we can get back to work in some capacity. The line that we have on this slide says they achieve more pain relief at 2 years. Well, they do. This slide represents 1.6 times as much relief as a standard low frequency stimulator. And that's only because this study was done for 24 months. we've been doing it for 8 to 10 years. So we still have similar numbers
Your
down-
numbers are better.
down the road. They're,
Yeah, so on average, your patients are getting 80% pain relief.
yeah,
And you have like a 95% responder rate, which means
Yeah.
95% of the patients are getting at least 50% pain relief or more.
yeah. And I'm very proud of that statistic. It's not me. I just simply put it in. I'm the technician. Elizabeth is the programmer, and the system just works that well. It makes me wonder when I have colleagues that don't do this system. Like I say, I worked with Medtronic closely, was hired by them for a dozen years to train doctors on how to use their system. And after the first one of these, I never worked with them again. And to put that in perspective, my own daughter was a Medtronic clinician. So she doesn't work for Medtronic anymore. But anyway, so more freedom. You can move around. The securing system that this company has to make the little wires stay in place is the best one made. I think that's been my specialty, is design and develop those systems. I designed the system for Medtronic. I think it's a fair system as well. This system is far superior. So I have not had to go in and move electrodes because somebody went out and decided to go bungee jumping and the electrodes moved a bit. Because there are 8 electrodes on each wire and we stagger the wires one above the other, even if they move a couple inches, we can reacquire that sweet spot I told you about at about the bra strap line. But again, no uncomfortable shocks, super easy to recharge. It's not a big burden. Most people don't even have to carry their remote control. You have an on-off power box. Most people don't even carry it with them because it doesn't require a lot of changes. And there's no restriction with sleeping or driving like the other systems. Is it safe? Sure. It doesn't interfere with anything. High frequency energy, like working in a cell tower area, things like that, you still have to pay attention to that because of the electronics. But most of you don't work inside that fence around a cell tower or things that could deprogram the system. It would always default to off. Nowadays, patients have an on-off switch anyway. When I first put these in 21 years ago, the first patient that I ever did it to had been disabled for 5 years. He had a very primitive early Medtronic system. He was a teacher in Utah where I trained. And he was so excited. He had done nothing. He couldn't do his job at the university. His wife was out working. He became a homebody. He was so excited after that little primitive system. There were only 4 electrodes on the early wires. And boy, did you have to be pinpoint accurate. And the very first thing he did when the stitches came out was get on an airplane and go to Hawaii. And he forgot and went through the high energy scanning system and it shut his system off. And at that time, patients didn't get an on-off switch. He got on an airplane, having forgotten not to go through that system, and flew all the way back to Utah to get us to turn it back on, got on an airplane, went back to Hawaii. That's how good he felt. And that was a very primitive system. Now, I only trained for 1 year at that location, so I can't say anything about follow-up, but by now I would have put this system in him if I had to replace any part. Will you feel anything? It's very unlikely you would ever feel anything from this. One of the more recent stims I put in, he had a little discomfort around the little pocket at the top of his butt cheek where I implanted the thing underneath the skin. And he's doing really well now. All he did was have some post-surgical pain. He came back a week or 2 ago. I injected some local anesthetic in the pocket. Now he has no pain in that area. But, you know, I don't like to see anything like that happen. That's rare that that even happens.
Dr. Barnett,
Enough not to have an infection. We do these things in a surgical area. And we put on a spacesuit and do this in a very surgical manner, the same as we would do for open heart surgery. So infection is extremely remote. Is this reversible? Yeah, you can take these things out. The trial is the same as the permanent without the implantation of the battery, and we pull those wires out after a week, if we can talk you into coming in for that appointment. When you pull that out, it's no different than having an IV catheter pulled out. You really don't feel anything when that comes out. But you get a test drive for a whole week, and that's certainly enough time for you to figure out, wow, I really like this, and I'm shooting over 95%. Can you have an MRI scan with it? Yeah, this particular system is fully compatible with a full body MRI. There are a few rare circumstances, but we'll have detailed discussions with all of you regarding this. You'll also have ID for when you need an MRI scan. In the rare circumstance where you can't have an MRI scan, a CT scan suffices. But there are circumstances, albeit quite rare, where you might not be able to have an MRI scan. My only time that happened is if I put a Nevro stimulator and adapted it to older Medtronic electrodes that were left in, or one of the other company's electrodes that were not FDA approved to be MRI safe. Or if an extension wire was used and a little metal screw in it is not MRI safe. But it's very rare that would happen. But the Nevro system is generally MRI safe. So I have a lot of experience with this. Again, this is a little older slide. This is from about 4 years ago. So now we're up to about 8 years, and I jumped on this as soon as I could when it first came out, and was certainly the first person to do it in this part of California. And I have never turned back. Again, we get, just in looking back at 8 years, every patient is over 80%. And if they fall down to 60%, it's usually a little change in the power is required, or maybe we can turn on a different set of electrodes on that wire, but it's usually easily managed, often quite remotely. But I have yet to pull one of these out because of patient dissatisfaction. And to be honest with you, I've given this talk a lot, and each time I mean to look it up, but I don't remember anybody that didn't want to have a permanent unless they had some other medical thing happen, or I can't remember. And that's not the case with the other systems. There are people that say, I'm going to feel this buzzing like for the rest of my life. And I say, well, yeah, pretty soon it becomes background noise. But back then it was a 3 or 4 day trial. And the patient said, well, I don't want that buzzing. That would bug the crap out of me. I have had patients with earlier systems, maybe we didn't screen them enough, that started having nightmares, that they had some foreign body implanted in them, and they started having nightmares that, oh my God, I'm a robot or something. And so you run across some weird things, but generally that's not the case with this or any other stim. But this is my choice right now. So hang on, we're going to change slides here a little bit.
I'm not trying to make them all.
Just a little technical thing right now.
Unmute me
Yeah, and then you
and I'll
can
walk away.
mute him.
Hey, doctor.
Hey, how you doing?
All righty. I just wanted to get my 2 cents in. I've
Okay.
never participated in this, but
Okay.
to all that are listening to Dr. Barnett, he ain't lying. I've got one of them in me. And actually, I have the second one because the first one's battery finally gave up on me. But I've had one in for years. And I have to say, it is the best thing you could ever hope for, both with my back and my peripheral neuropathy. Far better than any kind of medication, morphine, any other pills you could take. And
Good.
I don't know what I would do without it because I depend on it so much.
Well, I appreciate those comments, and you haven't had any problems with getting service. Elizabeth's a pretty attentive person,
Yeah,
and she's local as well. So we don't have to wait for someone to come from San Francisco like the old days.
The only thing I could possibly say is I've had some adjustment issues finding the best way to charge myself.
Yes.
Do
And
I charge at night? Do I charge during the day? How long do I keep it on? Things like that.
Sure.
But overall, it's absolutely perfect.
Yeah, unfortunately, there are ways to actually bring the device around to the front, but it's a long wire. The more wire we put in a patient, the more chance for snagging it or failure. So I've always put them on the back side, but I got to admit, we always ask people, which side do you sleep on? And then I usually say, please reach back and point where you'd like it. And I don't do it to remind me where to put it. I do it to make sure your shoulder works and you can actually reach back there. Because that is a problem in some of my older or arthritic patients. But it is hard to see behind you. So to put the charging system directly over the battery, yeah, I think that of complaints, yeah, we found a few where the patient said it doesn't work, and then we check them out and they're dead as can be because I haven't charged them. Well, because they kind of forgot, or maybe I implanted it so nicely that they don't even feel where the little lump is back there. But yeah, I wish I could say I could do that every time, but fortunately, the pocket, as we call it, where the generator is not a painful area. I have had to move a couple of them. And we do have some people that have more flesh than others to protect that device. But I appreciate your comments and certainly the success. In the past, I stopped using, even though it was an off-label use, meaning the FDA had not approved it. And you all know about the FDA and the ability to approve things. Even Medtronic, it was not approved for peripheral neuropathy. It was an off-label use. So I'd have to tell the patients, look, the government didn't approve it, but we know that it works somewhat. But the low frequency stimulator like Medtronic, I stopped putting them in for that off-label use because, to be honest with you, it was the hardest diagnosis to treat. It's not technically the hardest diagnosis to treat, but for me, it was the hardest diagnosis to make patients tell me that they really, really enjoyed the technology. So I stopped using those. This is now FDA approved for the high frequency stimulator, and I don't hesitate at all to put it in. And one of the things I wanted to say in one of the earlier slides is I have now, I think, over a dozen patients where, because I have 2 electrodes, I have patients with both neck pain, upper extremity, arm pain, like the arms version of sciatica, low back pain and leg pain. And I put 1 lead in the neck and 1 lead for the low back and have them both running simultaneously off of 1 generator. I only have 1 patient who I did that to that we had to put 2 generators in. And believe it or not, we got that through his insurance at $22,000 a generator because his power demands during the week-long trial indicated that he needed just a little more power to make it work. So we talked to his insurance company. It took a couple of years to get the original approval, but we called him in between the trial and the permanent and got approval to put 2 generators in. That's the only time that I've ever done that in my career. And he's doing great with both systems for both neck and arm pain, as well as low back and leg pain. But I've done at least a dozen Nevros, really just that I can think of off the top of my head, where I put an electrode in the neck for neck and arm and an electrode in the back for low back and leg pain. The new indication for peripheral neuropathy, I think we're going to get a lot more patients for that diagnosis alone. There are many, many off-label uses. One of the newer applications that surprised the heck out of me is to be able to treat an area that we've never been able to treat before, and that's the thorax. That's your mid-back, the thoracic spine. So wherever your rib cage is, and mid-back pain, whether it's a compression fracture or discogenic pain or post-surgery pain, I actually have been able to place the wires, thanks to Elizabeth, making sure I got all the information, so that I covered their mid-back pain. And I always had to say, I'm so sorry. There just isn't a lot of technology for that area. And now there is. And it works so much better than the half-hearted efforts that we made at treating mid-back pain before. So I really look forward to addressing pain in that area in more patients. But right now, I think the hot ticket is we have something that really works on peripheral neuropathy. and a painful peripheral neuropathy. We can't bring your nerves back to life, but we can make the fire in your feet and ankles, lower legs, stocking pattern, hands, a whole lot more tolerable. And putting a stim in doesn't mean you'll never get a shot. It doesn't mean you'll never take a pill again. It doesn't mean that. It means that we're gonna provide enough pain relief with this high-tech technology. And now I have about 8 years experience with this particular high frequency model that I feel really good. I would never hesitate to do this to my 3 daughters if they had to have it. Because number one, it is totally safe. Number two, it's totally reversible. Could bad things happen? Sure. The technical things of putting it in are usually not an issue with an experienced provider. I don't want to say with me. That sounds like you're bragging. But anybody who's done this for 20 years, the little technical things like you would get from a trainee at Stanford or UCSF generally don't happen because we've just done hundreds, if not thousands of these things. This is about as safe as doing an epidural. Technically, it's much harder, but it's about that safe. And we do epidurals without x-ray to pregnant people. So that technology has been around since 1903. So we've gotten a lot of technology now under our belts to make this a better system. But I just want to let everybody know that's listening. It doesn't mean that you don't need other care. It's not like we put it in to say, hit the road, we've done everything we can for you. No, that's what happens in surgery. We do an extensive surgery to you. You say it never worked, and we go, well, the surgery was perfect. I did everything I could. And any of you listening tonight have heard that. If you've had one or more surgeries, you've heard the surgeon finally tell you that. Everything I did was great. Well, that's fine. It just didn't help your pain. And surgery for pain control, we know, is only 30% effective. So if you went into that surgery thinking it was going to control your pain, you weren't informed adequately. Surgery is to save nerves that are going to die from impingement or pressure placed on the nerve or instability of your spine. Those are the two indications. You can look it up on Google. Yes, a surgeon, and I was in the neurosurgery group here in town for many years with Dr. Bybee, Dr. Remington, and I had 2 other pain associates. The reason they wanted pain people in the practice was they knew they couldn't help everybody's pain. So they were very upfront by saying, we hope your pain gets better. It often does, but this is not for pain control. This is to stabilize your spine and your nervous system. So I'm really happy I have this to offer everyone here. Dr. Rhodes, we've known each other for many years. He's got a great staff. One of them is a PA that worked for me for many years, Sue Schoonover. The other staff, we chat all the time. They have access to me 24/7. And they've been able to pick really good candidates that this technology has worked for. And I certainly re-review all the data before I offer this to you. And so far, they've been pretty good. I haven't had to turn down anyone for this because we have this great trial system of 7 days. So.
I have a quick question, Doc. You were speaking
Okay.
about the gentleman in the airport earlier.
Yes.
Does this device pass through the airport new security system?
It does.
Better.
It does. You also get an ID card not too long after you get the device to identify yourself as having a metal object in your body, very much like you would get from the Stryker company if you got a hip placed and so forth. So generally, they use the low energy hand wand on any human who's had a metal implant, just so it doesn't become frustrating for them either, because it will definitely set off a device, just like your keys in your pocket would. But they use the low hand wand, and the energy level is so low, it's enough to detect a bomb, but it's not enough to screw up the electronics of your system. Like some of the older systems it happened to, like the example I gave you. But no, very safe to fly with, very safe to, you don't have to notify anybody, but when you go up there, if they don't offer it at the TSA check-in, just say, I have an implant, here's my ID card, and they'll just bring you to the side and use the hand wand like that. Fortunately, for those people who have any doubts, Nevro has a program where you can actually speak to someone with one. And we had one of our patients online just a second ago. But they actually have a program now that makes the government happy too, without revealing personal information. But people have volunteered to talk to patients that might be considered for a stimulator placement. So you can really get firsthand information from a patient who has one in. And we can certainly, and Elizabeth can certainly arrange that for you. Should you have any doubts or you really want to hear from a patient who volunteered to give this information up. A lot of times we have to be somewhat of a salesperson. I hate to do that. Elizabeth is a salesperson. But we have to separate and just say, I do this for no money. I'd much rather be out to dinner with my daughter. But I really, really like this system so much that I want to make sure you all understand what it's like. And when you come into the office at any time, we can actually show you the models. You can get online at nevro.com and you can look at some of these videos and testimonials. They're readily available to you. And the partnership they have with patients can be made available to you as well. So you can hear someone who is not compensated in any way, shape, or form. I no longer do this for money. I did with Medtronic for many years. I don't do it anymore. And I don't use any other system. And I certainly have access to any device and any technology. But this is so good that it's all I would offer. If someone came in and an insurance company said, yeah, well, the other one is $5,000 less, we want you to use that, I wouldn't do it. This is a unique patented technology of high frequency energy. So for any of you that qualify, bring it up with your provider when you come into the office. If you're into the office on a Tuesday, I'm in the Surgery Center all day, every Tuesday. I come over here from Carson City, Nevada, as some of you know. And many times I'll step into the office and chat with the patient too, in between cases. Or Elizabeth may be here if there's some particular technical questions that you need answered. The providers have X amount of time, of course, between patients, but we can work something out for you should you have any concerns or questions. So don't hesitate, okay? You can certainly use me, but I know Elizabeth doesn't mind either.
I have a question. You
Okay.
were talking, most of your talk has been about the device being planted in for back or lower body. Mine is actually in the neck, my injury.
Yes.
So I forget what you called it, the pacemaker part.
Right.
Where would you
Yeah.
plant
Also down low where you can reach it.
that? Okay.
Yeah,
And
the wires come in a variety of lengths, and you don't feel the wires. You don't feel them under the skin or anything. So we plant it where you can reach. If you can reach to your hip or your flank, whatever is easiest for you. I always kind of measure. Well, first I ask you where you want it, right side, left side, what side you sleep on, etc. I also look at where your belt line is so that you don't have a belt rubbing on a previous belt. Just little things like that I've learned over the years. The only restrictions on putting one in the neck are there are a few patients, not very many people, get neck surgery from the back side.
that was my next question because I have plating in the front and rods in the back.
Well, it actually depends on the surgical note. If the surgeon rods are fine. I've put them between rods because rods go into the bone. They don't go through the epidural space. So as long as the epidural space was not violated, then the wires can slide up there. And I've done that several times. And it kind of looks funny because you have so much metal in the way and you can see the front metal as well on x-ray, but the epidural space is on the back side of the spine. So I think I've had one or two times where scar tissue up there from surgery, the surgeon couldn't remember, we couldn't get the notes. And then we found out they did have something that damaged the epidural space and the wire would not go in there. So that does happen. It's happened a couple times to me.
When you have well, I won't say current, an MRI from a year ago, February. So
yes. and it often will show us the space, but it won't clearly show scar tissue. So all we really need in your case would be the surgical notes, and the surgeon would tell us what part he had to damage when he did whatever work he did to you.
Oh, boy, that's-
Again, it doesn't eliminate you from consideration. We just have to look to make sure that I don't torture you. If your note says no, she doesn't have an epidural space anymore, then I would have to say
Right,
no, it
okay.
would not work in you.
Right.
But
Okay.
again, pretty rare, pretty rare.
I just wasn't sure how that would work because I have metal front and back.
Yeah, no, because it's off to the side, placed in the bones, and it's usually for stabilization. But in more modern times, we use it for stabilization, but we don't often decompress the spine from the backside anymore. It does happen,
I think
but in
mine,
modern times, we do almost all the decompression from the front. So that's
Well, what they had said is because that was surgery number 4, the last one from the front. that we did
yeah.
That they
And
could.
you were finally unstable is the problem. So,
Right.
but no, we
So,
certainly would review every part of your case. It didn't, for my part, doesn't cost anything. I can review your records. It's no charge to you because I just want the best for you.
Okay.
Good.
And if you guys want to either chat Dr. Barnett questions or raise your hand, we can unmute you and Dr. Barnett's happy to answer any questions you guys might have.
Hello, not so much a question, but a comment.
Okay.
Dr. Barnett was able to install a Medtronic system in me about 8 years ago. And about 2 years ago, we started talking about when the battery goes out, it's probably going to be time to look at a Nevro system. So we put a Nevro system in. It's just about going on 1.5 years right now. And what a joy to not have to feel all the electrical stimulation that the Medtronic system had. And my pain reduction has pretty much stayed at about 95% consistently. It doesn't mean that it doesn't have to be adjusted once in a while and the occasional pain shot. But for anybody that has the opportunity, I would certainly recommend this to you.
And far fewer
And,
injections
that's all I have
than
for today.
previously, huh?
Oh yeah, if I,
Yeah.
for the most part, if it's 1 or 2 every 6 months, I'm doing real well. And hopefully we'll see Elizabeth tomorrow for a minor adjustment with the stimulator
Perfect.
control. And if
And
not
for
her,
those-
hopefully Andy's there.
Yeah. And for the rest of the listeners, Scott returned to full-time work and has been working ever since.
That's a
that's-
long ways from getting off of the bed with full-time fentanyl to no pain pills at all and working full-time.
Exactly. So good outcome for Scott, and hopefully for everybody that qualifies to get it. Thanks, Scott.
Thanks, Dr. B.
Okay.
I don't currently have any more
Okay.
questions.
Well, thanks for logging on tonight to our talk. We'll be doing this periodically, and some of the information will be on Dr. Rhodes' website as well. And remember that you can get on Nevro, okay, nevro.com, Nevro, pretty simple. And you can see patient testimonials. You can actually see graphics about how these stimulators are put in and programmed. It's not rocket science, okay? And all of you will be able to easily understand it. It's not a big thing to undergo surgically. And when you get the permanent device, surgically, and when you get the permanent device, you have 2 small incisions that are about 3 inches long. One to place the wires and bury them under the skin, and one at the top of the butt cheek or the flank to bury the generator. So it's really not terribly invasive, okay? So thanks for logging on tonight. I appreciate it.